everybody. I would like first to thank Ashish Babulkar for his kind invitation to this wonderful meeting. Then, because plating is not a bed of roses, just UNIC has a place for treating 3 and 4 parts humerus fractures. My disclosures. What is just UNIC? UNIC is not an ORIF system, but an affair. That means open fixation by internal reduction. What is the goal of ORIF? Is a system to restore the humeral head, to give a room for tuberosities, consolidation of the tuberosities, and restoration of muscle effects. As we saw in the precedent presentation, ORIF in proximal humerus fracture has mechanical complication, whatever the system used. Because conventional ORIF devices accept a compromise impaction of the head on the shaft to achieve stabilization. Just UNIC is a system with 3 parts. A staple placed on the cancellous bone of the humeral head, a cementless stem gliding in the sleeve itself blocked in the diaphysis canal. And with this system, we can reduce progressively the displacement of the humeral head. You know the importance of preoperative planning, especially to detect if the medial hinge is intact and if there is a head split. Medial hinge intact means no risk or less risk of avascular necrosis. What is the technique? By a transdeltoid splitting, which is the best approach to do so, you open the deltoid and you see the humeral head, varus or valgus displays, greater tuberosity back and lesser tuberosity front. Gently, you reduce the humeral head by a regine and by finger, and you implant the staple at the deepest part of the humeral head, choosing between 4 different sizes. You impact the staple, you remove the spongious bone in the morse taper. This is the first one. And you drill 2 holes in the diaphysis to place vertical suture for tuberosity repair. Next step, you choose the appropriate size of stem between 3 sizes. And after choosing, you implant. After choosing, you implant the appropriate size of stem inside the humerus. You reduce the morse taper on the stem, and progressively you reduce the displacement of the humeral head by using the gliding system with a special punch. When on the C-arm the fracture is well reduced, you block the system with a screw, and you have only to repair the tuberosity by horizontal suture and vertical sutures. Some example, you see here the fracture, the staple in place, the stem, and progressively you see here the progressive reduction on the medial hinge, controlled by C-arm. Another example, before reduction, the distraction here, you lock the locking screw, and this is a perfect reduction of the displacement. Some example, here, 66-year-old ladies with a 4-part fractures, and the control at 16 months of follow-up. Another one, 55 years old, 3-part fracture. You see, pardon me, you see here the displacement. Here you see the medial hinge, first notch, second notch. You see the progressive reduction of the displacement. You can use it in more complex cases like this one. In this case, patient and surgeon were lucky because there was a totally destroyed medial hinge, but because the patient was young and osteosynthesis by just UNIC was stunted. You see here the control just after the surgery and with 2 years of follow-up with no avascular necrosis. In 2016, a part of the patient were reviewed, and you see here on these results the difference between the 3 and 4-part fractures with this system regarding the functional results and the risk of avascular necrosis. You see here 1 case of avascular necrosis in 3 parts and 5 cases on 15 in 4 parts. But because the prognosis is about the tuberosity's healing, so very often the avascular necrosis is well tolerated. You see here 3-part fractures, 2 years of follow-up with a good consolidation, good tuberosity's healing, good reduction of the fracture. You see this one, despite necrosis, the functional result is good with a weight content score around 100 pounds because of good tuberosity's healing. And with this system, tuberosities always heal. You see here a huge avascular necrosis, and it's possible without changing the stem to place a humeral head to do an EMI by a DP approach. So, as you see, intrafocal distraction of proximal humerus fracture is effective. It's easy to reduce the displacement by this system. It's easy to use. Thomas Gregory did a series comparing the junior and senior surgery in his service, and the results were the same in terms of time of surgery, of functional results, and risk of complication. It is a stable construct. Tuberosities always heal with this system. There is quite no problem with 3-part fractures. We observe 1/3 of avascular necrosis in 4 parts, but only 13% had to be revised. Thank you for your attention.